My just to let you all know, I'm having trouble with my volume, so please let me know if you have trouble hearing me. But just to introduce our first speaker, we have Caroline Stemofel, the Chief Strategy and Program Officer at AMCHP. She's currently serving as the interim CEO. She leads a team of maternal child health experts working to improve the health and well-being of women, children, youth, and families with a priority on strategic program development with a racial equity lens, evaluation, and data-driven decision-making, and partnering with people with lived experience. She oversees AMCHP's cooperative agreement and grant-funded work, assuring alignment with the strategic plan, synergy among programs, and continuous quality improvement. She has more than 15 years of experience in maternal child health, working with state MCH data systems. She received her bachelor's degree in natural science from Fordham University and her MPH in environmental epidemiology at Yale School of Public Health, where she focused on environmental health as it impacts MCH populations. So I will turn it over to you.
Great, thank you so much, and thank you for this invitation. Let me get my, here we go, slides to full screen. What's not in my bio is that I'm also the mom of 2 boys, and we live in Alexandria, Virginia, but I was born and raised in New York City, trained as an epidemiologist, but now a proud maternal child health generalist. And I just wanted to acknowledge as I move through this presentation that I originally presented this with our former CEO, Jonathan Webb. And so we really co-created and co-presented this information. So as with many things, I'm going to do my best to fill his shoes as we walk through activating MCH leaders for impact, reflecting on our past and preparing for our future. And I also wanted to acknowledge our workforce and leadership development team, Ben Kaufman and Grace Guerrero Ramirez, who helped to shape this content as well. And one of the things we'll touch on is that a leader is really only as good as your team. So all of our work is grounded in learning objectives. And so I looked at the objectives for this conference today and saw the objective to list one historical, present, and future issue for MCH. We'll definitely touch on those. And then to reflect on qualities needed to be MCH leaders of the future. We also ground our work at AMCHP in the MCH leadership competencies. So this presentation will touch on the MCH knowledge base and context and talk a lot about history. And then also centering the value of working with communities and systems. I have some key questions to guide us. I like this a little better than doing a straight outline. So these are things that I'm hopefully going to touch on throughout our time together. Who's AMCHP? How did Title V and MCH in America start? Why are we talking about a block grant and needs assessment? And Patricia was such a great introduction because I'll touch on a lot of the things that she talked about. What are the flexibilities and constraints of the Title V program? Why is there so much emphasis on data? And what are the levers you have as an MCH leader? Where does change come from? What does partnership and collaboration mean as we look towards the future of MCH? And then finally, what does an MCH leader look like? So first, to kick us off, who's AMCHP? The Association of Maternal and Child Health Programs. You may be familiar, but if you're not, we're a national resource partner and advocate for state public health leaders and others working to improve the health of women, children, youth, families, and communities. And through our strategic plan, A Bridge for Action, we refreshed our mission and vision. So AMCHP leads and supports programs nationally to protect and promote the optimal health of women, children, youth, families, and communities. And AMCHP envisions a nation that values and invests in the health and well-being of all women, children, youth, families, and communities so that they may thrive. So it was really important for us, even though it seems like a mouthful, to make sure that we included all of those populations in our mission and vision statement. So we're talking about women, children, youth, families, and communities, and we believe that they're all interconnected. So it was really important for us, staff, board, and members, to make sure that all of those populations were called out. And we have the privilege of being the membership association, working with 59 states and jurisdictions, implementing Title V and MCH programs, and we know that we're working with folks who are leading MCH programs, leading children with special healthcare needs programs, adolescent health programs, but also including families and youth in our membership and really centering the experience of people in their daily lives who are living the issues that we're trying to address. AMCHP is guided by our strategic plan and aligns our goals to some challenges that we can build around and work towards and measure success against. And our work is in two big pillars: infrastructures and issues. So we build capacity of our members to effectively address issues, and then we've outlined some key focus areas that we're prioritizing. And so we do this through technical assistance, identifying programmatic solutions and best practices, keeping our pulse on innovation and sharing that with our membership, and then learning what's working in the field and bringing that back. So we have the privilege of doing things like advocacy on the Hill for our members at the legislative level, and elevating what we know are the priorities, and thinking about things from even a media perspective, making sure that the funding and the issues that are most important to the membership are staying front and center. In June of 2020, AMCHP released our all-in statement that recognizes racism as a public health crisis. And in it, we share our commitment to dismantling structural racism, acknowledging where we failed in the past to be the allies that we should be, and issuing a call to action to join us. So this slide has some excerpts from the statement, but if you haven't had the chance, the link is on the slide and I'm sure we'll be able to share it. I do encourage you to read the full statement and commit to being all in as well. And this statement has been extraordinarily impactful on how we center our work. So I want to read you a quote from, I'll tell you who it's from in a second, but a quote that I think is relevant at this intersection of the past, the present, and the future. So children, it should be repeated, are not pocket editions of adults, because childhood is a period of physical growth and development, a period of preparation for adult responsibility and public and private life. A program of children cannot merely be an adaptation of the program for adults, nor should it be curtailed during periods of depression or emergency expansion of other programs. And so this is extraordinarily relevant, even though it comes from Grace Abbott, who was the second chief of the Children's Bureau during the Great Depression, is relevant today as we look at how we serve kids through things like telehealth and adapting to the COVID response, and watching things be emergency expanded and assuming that what works for adults will work for children. So it's really important not to repeat those mistakes of the past. So in order to lead well, we often think about the quote, "Those who cannot remember the past are condemned to repeat it." And we have introduced a friendly edit: "Those who refuse to acknowledge the past are condemned to repeat it." And so we're really here to make sure that we're learning from our mistakes. We also need to be truthful and have open eyes when we look at the past, and show that some of the fiercest advocates for women and children in our MCH history were focused on improving conditions specifically for white children and white families. And so we need to be truthful about the things like an emphasis on sanitary conditions and safety that were coupled with racist beliefs and practices that systematically discredited things like cultural midwifery practices within communities of color. And Tennille Bailey does a wonderful job of explaining and exploring this space in one of her recent articles around American midwifery is Black women's history and our futures. So we want to center the opportunity to learn from our history and to be truthful. So with that in mind, let's look at some of the key milestones for how Title V and MCH started in America, and acknowledge that much of public health history is maternal and child health history. So MCH really emerged from the movement to ban child labor and grew out of early social justice movements in the early 1900s. And so some of the key figures here, they're white female figures. Florence Kelley, Jane Addams, Lillian Wald, and Julia Lathrop were all working to bring an end to child labor, and they believed that bringing science and political will to bear to address social problems would eventually result in change. And so when we look at the Children's Bureau, this was really the first organized effort for children at the federal level. It was the first national government office in the world that focused solely on the well-being of children and their mothers. And it was put in the labor department because they were primarily concerned with children being in the labor pool, and focused on child labor laws, educational laws, juvenile courts, birth registration, and exploring infant mortality and maternal mortality. And then they endorsed activities like prenatal care and infant health clinics, visiting nurses, public sanitation, and education. And so they were the first ones to conduct infant mortality studies in 10 cities and connected infant mortality and poverty. And that was from 1914 to 1921. And so here you see some of the leaders of the directors of the Children's Bureau over time. And it was led by women until 1968 when it was restructured. And so now these programs exist within the Maternal and Child Health Bureau of the Health Resources and Services Administration under the U.S. Department of Health and Human Services. So we introduced this history of MCH to help you understand the context, the why of our work. Why do we do what we do? And what are some of the structures and constraints? And why are they the way they are? And so there's a brief timeline here. I'm not going to go through all of the different milestones, but we do have a 75th anniversary booklet that gives you some more in-depth information on the history, and recognizing that 2020 actually marked the 85th anniversary of Title V. And so now it's a time that we're looking to the future, and what do we want to be able to say when we reach 100 years of Title V. We also wanted to recognize that we're not just concerned with global or national history, but that the places in which we work carry their own histories. And as MCH leaders, it's our responsibility to really understand those histories and frame our work using that understanding, because it helps us to better serve the communities in an equitable manner. And so we wanted to recognize two examples where we've discovered, and not discovered, but we know that where we are matters. And we always talk about that place matters, right? Not just because of the current policy, systems, and environment, but because every place has its own history. Things aren't just the way they are, systems are made. And so understanding how we get here helps us to understand what we have to do, and in many cases undo or dismantle to get to where we need to go. So on the left side of the slide, we have Louisville Metro Health's equity report, which detailed a timeline that grounds the reader in the history of Louisville, from colonization and slavery to redlining, white flight, and refugee resettlement. And then on the right-hand side, Dr. Kimberly Weich Etheridge spoke at AMCHP's 2016 conference about infant mortality and the social determinants of health in Nashville, Tennessee, but first grounded us in an understanding of the historical foundations to tell the story of why there are huge disparities in infant mortality between Black and white infants. Again, it didn't just happen. Things were created, systems were created, and you need to understand that if you're going to undo those systems. So for a moment, I'm going to introduce a few opportunities for reflection, and you can jot these down or think about them later when you have a chance. But thinking about what resonates with you from the history of MCH. What do you want to learn more about? Who has inspired you in your leadership journey, and how are they in touch with the history of MCH, the place they live and work, and the institutions and organizations for which they work? So I'll shift now to what does Title V currently look like, so that we have that context for our understanding of flexibility and constraints. So Title V is the legislation that provides the funding stream for states and jurisdictions to work in improving maternal and child health, and it's embedded in the Social Security Act of 1935. So it's actually the longest standing piece of federal legislation, and it's the only program focused solely on improving the health of mothers and children. So Title V got to where it is through a variety of legislation. Some of that was listed on the previous slide, but overall we're looking at Title V as being the way that funds are appropriated and used for the items on the slide, which is not by any means an exhaustive list. And then we also talk about support for special projects of regional and national significance, or SPRANs, which also comes out of the Title V allocation. And SPRANs is used for research and training for MCH and children with special healthcare needs programs, and it's funding to assist states with implementation of their block grant programs. So for example, AMCHP receives SPRANs funds. Title V became a block grant under the Reagan administration, and this was a time where people were changing how they thought about government. And so we think about it as a sea change. Reagan was elected on a platform of giving power back to states, and the block grant was seen as a solution to do that. And so it was a technique to combine all of these federal categorical grants and health programs into one block grant, which was meant to provide lots of flexibility and allow states to really guide how the money is spent and reduce overall administrative costs and oversight. And so you can see what the programs were that were consolidated here. And then finally, I wanted to tell you just a little bit about how things work for Title V each year. So starting with a needs assessment, every 5 years, states conduct a needs assessment to understand their priorities, and then shape an action plan from that needs assessment. And then annually, they submit a block grant application that outlines their strategic priorities and their activities for the year. And then they report on national and state performance measures and other measures, including evidence-based and informed strategy measures. And so the performance measurement framework is designed to demonstrate the impacts of state Title V programs. And I'll talk more about the data framework in a little bit. So why a 5-year needs assessment? We know that people make important decisions every day in the absence of data. And we don't always know why, but we have some ideas. It could be that the data that they need aren't accessible to them. It could be that they've never seen the information configured in a way that it made sense. Or it could be that they didn't even realize that there were relevant data for the decisions they need to make. So lots of reasons why people make decisions without data, but we know that in order to achieve the best outcomes for people we're serving, we need to be grounded in the best available information. So that's really what the needs assessment process is all about. It's creating an accurate and complete picture of the strengths and weaknesses of a state's public health system. It's helping to inform priorities, understand gaps, and set the agenda, and then to understand how to allocate and develop available resources to meet needs. And ultimately, we're looking to improve maternal, child, family, and community health outcomes. So here's a little bit about the flexibilities and constraints. There's lots of nuts and bolts in the block grant, but I wanted to highlight just a few. So some rules you need to follow. There's a match requirement. So states must match every $4 of federal Title V money that they receive with at least 3 non-federal dollars. You also have to be able to report on that and demonstrate that you've made your match. You'll also hear people talk about 30-30-10, and this is the requirement that 30% of the funds need to be used for preventive and primary care services for children. 30% of the funds are used for children who need special health care and special services and programs, and then no more than 10% can go towards administration. So those are the hard and fast constraints. There's also requirements around systems and coordination and having to document certain partnerships like the Memorandum of Understanding with Medicaid as part of the Title V process. And there are a lot of reporting requirements. The block grant annual report is certainly hefty, and you must report on the 5-year needs assessment each year, giving an update. And you must, in both reports, reflect the health of the entire maternal and child health population in the jurisdiction. You can't just focus on folks you serve directly. So you can include lots of information, but there are some things that you must include. And then there's forms that go along with all of that information and requirements. So we feel like it's really important to understand that there are boundaries for certain programs like Title V because there's so much flexibility. So things can bend, but you can't bend so far that you break through one of the constraints. So reflecting on that information, how do you react to constraints in your work? Is a constraint truly a restraint? Have you ever heard the phrase, oh, we've always done it that way? And that might not be a real constraint. So, keeping in mind that there are hard and fast rules, but there's other ways that you can get through perceived restraints or perceived barriers. So, we know that people stop asking for something if they're always told no, and that's maybe not a real barrier, but that information is available, it's just not accessible. And we talk about this a lot in quality improvement. Are we doing something because it's always been done, or have we really examined that process? If we really live those quality improvement principles, every system is perfectly designed to get the results it gets. So if you want something different, you have to do something different. So next I want to talk, this is my heart space, data is my jam. So why is there so much emphasis on data in the block grants and in the MCH? And so again, this has its historical roots in the Children's Bureau, where it conducted research and studies on infant mortality and child nutrition. And it was really important in that moment in the 1930s where 40% of the nation's population was considered impoverished. And so these are just 2 examples of examining things like infant mortality seasonality and what we call the baby thermometer relating infant mortality to to income. And in this case, it was specifically father's income. And so we know that when we emphasize data, what gets measured gets done, and our measures reflect our priorities. And then these are just a couple of graphics to show how the measurement framework for Title V hangs together And so we know that Title V still transforms to this day, even though it's gone through many transformations in the past. And so just to think about how things hang together, there's 15 national performance measures. They're addressing key MCH priorities, and then they're tied to national outcome measures. And all of these things link back to the strategies that a Title V program is selecting to have an impact on those outcomes. And the punchline of all this measurement is really about accountability and impact. And that's what we mean when we say accountability, in the sense of, here's what we're hoping to achieve, here's how we're planning to get there, here's where we ended up. And that's an important element of any programmatic effort. And we talk a lot about program evaluation as being really important. What's the point? What's the so what? There are a couple other things I want to call out on this slide. In the upper left-hand box, the yellow box, it talks about the investment in Title V is more than $6 billion. That's a huge investment for maternal and child health. Again, many other programs in the government cost us a lot much more money. So what's the way that we can tell the story of how those funds are supporting the populations and the activities that we are doing through Title V? And so, AMCHP has the opportunity and the privilege to go to the Hill and to advocate for that Title V allocation. And often what we're trying to do is increase that amount of money. It's a lot, but it's still not enough. And so the data help us to tell the story at that legislative level. Another box to highlight is on the on the right side, the second yellow box, talking about the fact that Title V is reaching 48 million children served, and 2 million children with special health care needs are supported directly or with enabling services. And that's what we talk about when we talk about impact: who's reached, who's impacted, who is being helped by this, and how do we tell that story? So as you're trying to identify the levers that you as a leader are trying to impact and influence, it's really important to understand the root causes of the outcomes that you're seeing. So we know that there's been a lot of conversation, a lot of protesting, a lot of action around equity and social justice and addressing racism, but we know this isn't new to our country. The conversation has been turned way up in terms of the decibel level, who's able to hear what we're talking about. And so it's really important to root these discussions in the root causes, and thinking about that racism as a root cause of the outcomes that we're seeing, and be mindful of which lever we need to pull in order to address those challenges. I did want to acknowledge that in the spirit of quality improvement and learning from each other, we've stolen shamelessly from a respected colleague, Dr. Michael Warren, who's the Associate Administrator of the Maternal and Child Health Bureau. So you may have seen this little graphic before, because he talks about this in his approach to addressing the issues we're facing in MCH. And so he talks about accelerating upstream and together. And in the work that he describes, he's talking about not getting stuck in the things that we've always done, but being able to move more quickly to address some urgency in accelerating our work. When he talks about upstream, he shares this story, which is really a public health parable, about the gentleman who's walking by a river and sees people who are floating down the river and they're drowning. And then this gentleman jumps into the river and starts pulling people out. And he's there for a long time trying to pull all these people to safety. Someone else is walking along and sees this man pulling out people from the river and then walks away. And the gentleman in the river, who's still working to get folks out of the river, says, "Where are you going? Why don't you stop and help me?" And the other man says, "I'm headed upstream to see why people are being thrown in the river in the first place." And that's our punchline, right? Looking at the systems and the levers that we're trying to pull, we need people who are helping folks get out of the river, right? We need to save folks from drowning. But we also need people to go upstream and find out what levers we can pull systematically so that nobody gets thrown in the river in the first place. So even in that example, we have to think about the fact that one person can't do it all, right? So thinking about doing this together, you need multiple people involved and engaged, working together to advance equity, to create just systems, and dismantle the racism that's directly impacting the communities that we serve. We often talk about knowing about health inequity for a long time, right? We can trace a lot of our knowledge now back to things like unequal treatment, which came out in 2004, and people who have been studying disparities long before that. But what is going to get us there? What gets us to a just and equitable society? And so when Jonathan and I talked about this idea, this concept, on the one hand, we felt like, well, if you're a new entrant into the conversation, we absolutely, as a leader, want you to get a firm understanding of the history and knowing where we came from and understanding what the challenges are. And we really applaud people doing the work, right? Getting educated, understanding and doing your reading and having those important conversations, but recognizing that this isn't a new issue, right? So on the other hand, information is out there. Things are heavily researched in terms of disparities and the impact of racism. And so at some point we need to be urgent, right? Thinking about that acceleration, being urgent about not having that analysis paralysis, and talking about learning and learning and learning, but not applying. So understanding what got us here, but then also identifying those action steps that will get us there, accelerating that movement. So thinking about that movement, where does change come from? We know this isn't an exhaustive list, but it's a good possible place to start in terms of change levers. So many of you may have constraints on the big levers that you can pull. You know, it depends on the kind of organization that you work in, whether or not you have the ability and the power to do some of the things that we can do at AMCHP in terms of advocacy and having national level conversations. But there's a connection between those big P policies and politics and the little p policies that you have the ability to impact in your everyday life and work. If we think about systems, we're trying to impact systemic racism. So we have to look at how we're changing the system because we know it's perfectly designed to do what it's doing. So if it's putting people in positions where outcomes are desperate, how do we change or dismantle that system so that the outcomes are more equitable? And consider the environment around you and understanding the political landscape. We also want to talk about community engaged work as another lever that you have. There are so many assets that are worth building and supporting in every community, but there might be barriers in that community that are preventing those from becoming large scale solutions. So how do we work alongside communities to really get them engaged in the work that we're trying to do and do that work alongside them so that we're not coming into an environment with a paternalistic mindset that says, you know, here's what we think you should do and are you along for the ride? So if you are looking to make change and be a change agent, it's important to understand who the gatekeepers are within systems and within communities. So when you have folks on your team and you're looking to make some innovative changes, you need to identify the individuals that have influence and can work with you at the table. And then thinking about activation, right? Activating leaders is not just a strategy for decision makers at the top. We often think about leaders as being directors of something, but there are leaders who work in communities and leaders who are working in the trenches. So understanding how to engage, motivate, and align with those folks is more impactful than we can actually get credit for. And Jonathan, who co-created this presentation with me, was a true huge believer in teamwork makes the dream work. And so we know that the challenges that we're facing are too large for any one person, any one organization, even any one state to do by themselves. So how do we strategically partner and collaborate with those around us? So when we think about what does it mean to partner and collaborate, we know that the challenges that we're facing are rarely isolated to just maternal and child health or just public health. So we're getting outside our spaces, engaging other players, and thinking about who's impacted and who has a stake in the work that we're doing. So thinking about healthcare, clinical partners, housing, and corporate partners. All of these folks have a vested stake in making sure that we have a healthy workforce, that we have healthy communities. So how do we do that and think about the full life course theory and social determinants, thinking about who we engage in those key conversations. We also want to avoid that scarcity mindset in leadership. We know for leaders in Title V, there's a history of being asked to do more and more and more with less and less and less, but we don't have to stay there. So we want to create possibilities and align our principles so that we can advocate on other behalf with people in our other networks and think about ways to expand our tent. There's room underneath our tent for all of these different partners and approaches. Something else we've been exploring as we build partnerships is having clear expectations for what those partnerships look like, being strategic and thoughtful, that there's essentially a beginning and a middle and an end. If we're trying to solve this problem that's, a 3-year time arc like we have for our strategic plan, what are the bite-sized things? What do we need to do in the next 6 months to make that reality? And that really helps to bring partners in and keep them engaged, because it's not this unending engagement with no end in sight. We're getting close to time, I think, but I did want to just talk a little bit about what an MCH leader looks like, and just note that I'm inspired by individuals who have a firm understanding of the past, but have a really strong vision and are looking to cultivate that vision for the future. So all of these pieces are components of what an MCH leader looks like. And I wanted to encourage you to take a look in the mirror, because anyone can be a leader, whether they're in a director position or not, whether their title indicates it or not. You can lead from where you are, develop your voice, your brand, and cultivate your influence. So being a leader isn't just something that you're born with, it's a skill that you can learn and grow and develop. I know the theme of this conference is around resiliency in MCH populations, but we also need resilient leaders. And so for your final reflection, think about the opportunities you have to lead from where you are, what skills you need, what strengths you can build on, and how you'll be an agent for change. So thank you.